There is no question that cultural and identity factors are crucial in mental health care. Factors such as race, religion, sexual orientation, gender identity, and socioeconomic status all shape a person's mental health journey and their interactions with the mental health care system. Over the next 90 minutes, we want to explore not only how addressing these topics is critical to the care that you provide, but also what we can learn about ourselves during patient and client interactions. From implicit bias to systemic barriers, we're going to talk through some real world challenges and strategies in hopes of strengthening connections in the clinic. And to that end, we have enlisted the help of two seasoned healthcare professionals. Dr. Lisa Coyne is a licensed clinical psychologist and prolific author and popular speaker on the topics of anxiety, OCD, and parenting. She is an assistant professor of psychology in the Department of Psychiatry part-time at Harvard Medical School and an internationally recognized acceptance and commitment therapy trainer. Dr. Christine M. Crawford is a psychiatrist specializing in adult, child, and adolescent mental health. She is an assistant professor and vice chair of education in the Department of Psychiatry at Boston University School of Medicine, and she currently serves as the associate medical director for the National Alliance on Mental Illness, or NAMI. Lisa and Christine, thank you both for joining us today. Lisa, I'm going to start with you. There is no simple way to describe ourselves. We are all made up of a variety of factors such as culture, race, gender, faith. Why are these factors so important to consider when it comes to our mental health?
I think that as we move through the world, who we identify as, with these multiple facets that you describe, right, both influences and organizes how we behave and how we are perceived by others, organizes how systems and individuals respond to us. So it's important when I think for me as a clinician to really fully understand the context in which my clients are operating, and all those aspects of their identities which are very important to them, and also which, because of patterns that are happening in culture at large of discrimination, oppression, and prejudice, may be impacting them. And as a clinician, also, it's important that I also am aware of how I might be perceived based on how I look, my age, the color of my skin, my gender, right? Because that can also have an effect on the therapeutic relationship. So I'll just start with those things.
Fabulous place to start. And Christine, do you want to add anything to that list of considerations that Lisa has put out there?
Yeah, I think it's important for us to not make assumptions about aspects of a person's identity that is more important to the individual or aspects of one's identity that's more valuable over the other. And I think having conversations with our patients coming from a place of curiosity about wanting to understand them as an individual, because everyone has their own lived experience, but the only experience that matters in that room during that patient interaction is the experience of the patient. And so I try to create an environment that allows the patient to be as open and honest about what it's like to navigate the world as themselves. Not what it's like to navigate the world as a Black person or of a person who's part of the LGBTQ plus community. What is it like for you to navigate the world? And start from there rather than making any assumptions about parts of the person's identity that has the biggest impact on their overall life.
Great points. Lisa, we sometimes hear the term intersectionality used when discussing how culture and identity impact mental health care. Can you explain the term and how it's relevant to our conversation today?
Sure. I think, there's different ways of understanding it, but in general, it refers to sort of different facets of one's identity that are important to them and how those facets of identity might amplify or mitigate or create experiences for them. For example, I work with a lot of trans youth. I work with a lot of kids with anxiety, OCD, etc. And those might be viewed as intersecting identities, which make their lives more stressful given sort of systemic racism, oppression that goes on, and the things that are happening in our world today. And so as a clinician, it's really important for me to ask lots of questions. And just as Dr. Crawford has said, be curious and be humble about their particular experience in their friend group, their school, their family, their neighborhood, and thinking about these sort of widening circles and how those overlapping facets of identity might have something to do with their experience.
Thank you, Lisa. Lisa and Christine, what you both shared suggests that it's important to understand that not recognizing the existence of these identity factors could have a negative impact both on care and on a patient's perception of healthcare. At the same time, determining all these identity factors up front seems unlikely when first getting to know a patient. How quickly, generally speaking, do you try to get to the bottom line in terms of determining most of these factors for your patients? Christine, do you want to take that first?
That's a really interesting question because it's all up to the patient, and the patient dictates and determines the pace of anything that's happening in that room, especially when it comes to something having to do with identity. As already been discussed, it's hard for people to be open and honest about disclosing what their true identities are or facets of their identities if they don't feel comfortable with you. If they're just getting to know you in a session 1 or session 2 and they're still trying to figure you out, right? They need to figure you out and feel comfortable with you first before even bringing up or feeling comfortable bringing up aspects of their identity. So my priority is really to establish the therapeutic alliance first, then make sure that the patient feels comfortable and really kind of following their lead to see what makes sense in terms of their pace. Now, if a patient is presenting to me, and this has happened before, where the overwhelming majority of the distress, the emotional distress that they're experiencing, is directly connected to an identity that other people have labeled as problematic or has marginalized, and that is the main factor contributing to their distress. Then yes, we're going to talk about it from the jump, probably because the patient is bringing it up from the beginning, right? But if it's an issue, not so much for the patient in terms of their identity and how it is that they're viewed in the world, and it's not directly having an impact on their chief complaint, then I don't need to kind of poke and prod from the jump. I'm really focusing on the alliance and addressing what their immediate concerns are first.
Lisa, I see you nodding your head. Did you want to add some to this part of our discussion?
I'm just agreeing wholeheartedly with everything Dr. Crawford said. And I think that one thing that shows up for me is to be really mindful of things that we can do as clinicians that get in the way of building that therapeutic alliance. For example, making assumptions, as we discussed earlier. And I think meeting your client where they are is of the utmost importance, and letting them set the pace is great.
Let me follow up on something you just said because this is an important question. Do you find that there are some common identity related blind spots that providers have?
I think that for newer, I mean, I'll speak for myself, and I train a lot of clinicians these days. And I think that one thing that shows up is we focus on our clients and our patients and try to meet them where they are. And I think we have to have a really equal assessment of how are we being perceived? Is there something that we are doing or some way that we're appearing that is off-putting or constraining or that might be an obstacle? And that can be hard, right? Because if for example, I'm not culture matched with a client who feels like there's some sort of power differential, or if I am part of a majority group and um, you know, I have a client who is not matched up with that, that could be daunting for that client, and it could be hard, and it can be vulnerable for providers to feel like, oh, I didn't mean to do anything wrong, but here I am, and this is hard. And so I think really coming to the table with cultural humility, awareness, curiosity is just essential.
Christine, I want to ask you to dial in a little bit on visible versus invisible aspects of identity and how you might approach them differently.
That's such a great question because when people think about identity, for the most part, it's like there are distinct categories that they tend to have in mind: race, gender, sexual orientation. And they just have this like pretty concrete list in their head around visible identities. But some of those identities can mean absolutely nothing to the patient, but these invisible identities. And I don't even want to label what some of the invisible diagnoses or visible identities are because they look so different for other people. There are some people who have a certain identity that's invisible having to do with the underlying medical condition that nobody would be aware of. Someone can have an identity attached to a traumatic experience that they've had in the past. Someone could have an identity being a parent, being a caregiver, taking care of an elderly family member, right? These are all important aspects of a person's life that we can't see, but we need, again, to be as open-minded as possible about what identity means for our patients and not just limit ourselves to looking at the color of someone's skin, how tall they are, sexual orientation or gender they are. That's where we fall into these pitfalls, right? And this is where we make the error. But every single time we sit with someone, you got to start with a blank slate. I really do believe this because when people come into these interactions thinking that they've done all the work, right? They read all the books, right? And they do this whole performative wokeness sort of approach where I understand, I understand. You don't understand, right? You absolutely don't because you have not walked in my shoes in life at all. You've only navigated life as you, right? And so that's why we have to go in with a blank slate. Tell me about what your experience has been like. I'm so curious, are there aspects of your identity that are really important for me to know so I can best support you? That's how we should be having these conversations. And if you're able to ask those type of questions from the jump, the patient's going to be like, okay, this person actually is interested in getting to know me, and maybe I'll give them a chance.
There is a clear theme developing in our conversation. That's curiosity. And I love that it goes along with humility in terms of just working with your clients and patients in a way that serves their best interests, patient-centered care. Lisa, do you find that some people shift their primary identities based on their current situation or the company that they're with?
I think it really depends on the person, I think it depends on what are the things going on in their life and what are their resources for coping and what's their learning history, like what have their experiences been so far. I think that all of us are, one of the things that we do, right, is adapt our behavior to context and situation when that's helpful to us. And sometimes we aren't, it's harder for us to do that. So I know that for some people, myself included, if you've had a very fraught and difficult day, your assessment of yourself and who you are is going to be really different and maybe more negative than if you've just had, an amazing experience of success in your life. You might feel like you're on top of the world. And I think that identity really intersects with those sorts of contextual experiences all the time as well. And again, I guess this points to the idea that identity can be very fluid as well. And so it's not like you ask questions and then you know who this person is. We're all different in different situations. And so it needs to be ongoing and it needs to be something that we stay curious about through the course of the work together.
I want to talk about systemic issues that we should work into this conversation. Um, Christine, what are some of the systemic inequities that you've seen that create barriers to mental health care for particular populations? Can you speak to that?
Yeah, when it comes to barriers to get the mental health care and treatment that everyone should be entitled to, you're right, there are these barriers, and a big barrier for a lot of folks is access, availability of mental health providers within their community. What we know to be true is that there are some communities that have a wealth of resources and others do not. And that's secondary to structural racism. And the impact of structural racism because of certain policies and practices that were established long ago, we're still seeing the ongoing effects of that. And so we need to be mindful of the fact that even though we're in 2025, we're still dealing with the, negative impact of 1965 or 1964. We're still seeing it, and people are still, struggling to be able to get out of poverty, to establish generational wealth because they didn't have access to that earlier on in terms of their family's history, right? Thinking about not only poverty, thinking about structural racism, but I mentioned access to mental health care, but also when it comes to access, there's an issue having access to providers who are able to have the cultural humility that would allow people from marginalized communities to keep showing up, to return to their follow-up appointment with their outpatient therapist or their psychiatrist, to feel comfortable going to the emergency room if they're in a crisis, because they've heard bad things from other people in their community about the care provided at XYZ Community Health Center or this hospital. So we also need to be aware of the fact that us as providers, we can actually contribute to some of those inequities, right? So even though we have a hospital that has X number of psychiatrists that are available to everyone, it's the availability is going to be experienced differently based off of your identity and which community you're a part of, because even though there's 20 psychiatrists there might not be one who understands, who's curious about your experience, and then you won't be able to access care and get the most out of it. So it's interesting that we can actually contribute to the problem as well as providers.
Let me ask this as a follow-up for either of you to jump on. Is it important to address or acknowledge the systemic bias with your own patients? I mean, is it good to put that on the table if it comes up in discussion, or do you proactively put it on the table?
I think yes. I think absolutely it's really important to talk about. Um, I think about how even in healthcare, there have been studies where they have matched people with identical symptoms, and the only different factor is race or how they appear. And objectively, there's data to suggest that people of color don't get as quality care as people who are white, for example. And I think, to go and work without knowing that and without kind of keeping that in mind, that might be something, for example, there are many other things as well, I think is really important, right? Because the goal, again, is to create a safe space for this one individual with their unique experiences as they move through the world, with what they hold as important and essential to them, to create a safe place for them to have trust, to share what would be helpful to move forward, and to feel safe enough to do so.
Christine, anything you want to add to that?
Yeah, I do think it's important for clinicians to be aware of some of the disparities related to some of the conditions that we treat and the inequities that currently exist, because they're not in denial of the fact that these differences do exist and have an impact on care, have an impact on their prognosis and how it is that they respond to treatment. So I think clinicians having that awareness is very, very important. While at the same time, I do think that clinicians shouldn't feel a sense of urgency to put that on immediate display, because you're only doing it to mitigate your own anxiety, that you got it. Like, oh, I know what's going on and this and that. But just to kind of pace yourself and don't fall into this trap where,
Yeah.
again, like this performative display of wokeness of, well, I see that you are Black, and given that you are Black, the statistics show nobody wants to hear that, right? As patients, but they want you to be able to acknowledge it if it's going to have an impact on their care, right? Or if they happen to bring it up. So a great personal example I'll bring up and mention is that when I was pregnant with my first child and I met with my OBGYN for the very first time, and this is my first pregnancy, I asked this woman this question because I felt comfortable asking it and I wanted to know what her response would be. And I said, do you approach the work that you do, the clinical work that you do, different when it comes to taking care of Black women just because of all the data that we know of maternal outcomes? And her response was, well, everyone's the same to me, and I don't really think about the differences in terms of outcomes. Now, that wasn't great for a couple of reasons. Number one, she didn't acknowledge the actual data. The data does exist that, you're more likely to have an adverse event as a Black pregnant woman compared to other groups. The fact that she was in denial of that was concerning, right? And also, she didn't explore or kind of be able to tolerate sitting in the moment and being curious about that, right? She felt the need to provide an immediate response. When what she could have done was she could have taken a step back and be like, what an interesting question. I wonder what's behind that question. I wonder why it is that you're asking the question. Because I could have shared a story about, well, my sister died giving birth, and I'm concerned about myself. You know what I mean? Versus I'm working on a term paper and I just want to know how you're approaching it, right? And so it's important to understand, why are you asking the question? What is behind this? And I think that's a really, again, a great way to further enhance that rapport, to establish that trust. Those are approaches that clinicians can take.
I have so many questions for you both. Let me ask you, Lisa, to weigh in on this one. Do you find that some common cultural differences impact how a patient expresses their distress?
I think it's unique to the patient, to be honest. I think that that's something that I listen really carefully for to see. I know that there's tons and tons of variability, and I wouldn't want to, within group and between group, about how that happens. And so what I focus on is this one individual in front of me and listening really carefully and really closely about how they're talking, their inflection, and what words are they using? How do they understand what's going on with them? Do they understand, for example, anxiety in a more physical way than in an emotional way? Are there not words there? Um, and I try to match that if I can. And then if it's helpful, to try and come to, help them either, come help us come to a common language that we can use to refer to things. But I think it really is down to really listening closely to that one individual with you in the room right then and there.
And Christine, you've talked so much about curiosity and the importance of asking these questions of your patients. What do you do if you find that there is a bit of a language barrier or perhaps cultural filter that impacts your ability to communicate with the patient?
Yeah, I actually have one specific example that comes to mind. I work with kids and teenagers as well as adults, and especially when it comes to thinking about providing care for kids and teens, it can be really complicated because we have the parents and the families who really are weighing in heavily about what the treatment should be, what decisions should be made. They have a direct influence on the overall care. And I worked with this one individual who the family was from Ethiopia and they just arrived from Ethiopia. But the patient himself had been in the States for quite some time. In fact, came before the rest of his family came. And this was an individual who was experiencing symptoms of psychosis, and they were really struggling communicating that experience to their family. They didn't even have language to describe the experience of psychosis within their culture. And so, what I actually did, because the patient was struggling with how to communicate this, I wanted to be supportive of the patient. I asked the patient, who in your community do your parents turn to or other people go to if they're having difficulty, if they have questions that they don't know the answer to? And he talked about a religious leader in the community. I actually called this individual up and asked for, any recommendations to share with the patient. I actually invited him in to future sessions. We worked together to come up with the language, the questions, and then we had a session with family, religious leader, and patient. And really, it was that religious leader who kind of served as the interpreter, not just for the language, but for the culture, and to identify the language that best reflects what it is the patient was experiencing so that everybody was on the same page. So that was an experience of me. I didn't know, I didn't have the answers. I asked the patient, like, how should we do this? Right. And I was entirely comfortable, not saying that I put it in the hands of this religious leader, but we were working together, right? And I had enough humility to be like, it's okay, you can direct this conversation. Here are my contributions. But I was fine taking a back seat as, this religious leader was navigating this really complex discussion. So that's one thing that comes to mind for me.
I love that. Again, going back to the curiosity and the humility. Lisa, let me pause right here and ask you to weigh in, specifically talking to our viewers who are newer to the profession. There might be a time early on in your career where you feel like you need to have all the answers, and that the approach that Christine just suggested might somehow suggest that you're not qualified correctly, almost the opposite of humility, and insecurity, if you will. Can you speak to that?
Yeah, I think the longer I am in this profession, the less I know. Put it that way. And I think that what I would encourage younger practitioners to do is to make friends with not knowing. Make friends with being uncomfortable, make friends with asking questions, and hopefully it's appreciated, right? And like you'll learn more about that individual. And I think that if those questions come from the intention of really creating a safe space, of really knowing that person wholly as a whole person, right? And finding ways of communication that work for them, I think it's going to be really well received. I think where clinicians can go wrong, and I think we've touched on this before, is acting like you know all the answers, that you've done the work and you've studied and all this stuff. I mean, no one really does want that. What they do want is someone who they feel like cares to know who they are and wants to look from behind their eyes at their experience, and acknowledging that we can never fully really do that, but we can try really hard and with deep intention to do that. So again, making friends with the not knowing, asking good questions, and really staying to listen for the answers.
I like that. Christine, a specific question for you while we're talking about diagnoses. Are there any red flags that clinicians should look for that suggest a person's sense of identity is being shaped more by an illness than by the lived identity?
Well, I think as a psychiatrist, I just live by the DSM-5. It's just in my head, right? And I do that because that's how I'm trained, and I'm a diagnostician. And so, because the DSM-5 is in my head, naturally, I'm thinking about how to put some of the experiences that a patient has in certain categories, in certain buckets. Like, it's a natural thing that I do. When I find that I'm having a hard time figuring out which bucket to put someone in, and it's making it hard for me to understand or to decide what steps I should take next in the treatment or in conversations I should have with the patient, then I pause and I think about, okay, well, what is this experience and why is it that I'm having a hard time categorizing that? Does that mean anything? Is this of significance? Or am I not fully understanding this patient's experience? And so, especially as someone who's worked with a lot of people who have lived with psychotic symptoms, this comes up a lot, right? And there have been situations that I've been in where I would have someone, as a medical interpreter while I'm interviewing a psychotic patient from a different culture. And I'm seeing kind of the wheels turn in the interpreter's head. They're kind of like, wait, what? And they're trying to understand. I'll stop the interpreter and be like, wait, what was that about? Like you were kind of like pausing and thinking. And then we'll take a time out and the interpreter will say to me, I don't really understand what they're trying to say. I don't know if it's reflective of a thought disorder. I don't know if they're struggling with like me translating what it is that they're saying because I don't know what the words are. So we just kind of like stop and we're real with each other. And then I tell the interpreter, I'm like, can you tell the patient what it is that we're talking about and kind of what our current challenge is right now? And let's try to work together so that we can best understand what it is that you're going through so that I know how best to help you. And I always put it in the context of that. I want to better understand this experience because that will give me an opportunity to be able to take better care of you because I'll know what to do. And so, even though we can be friends with not knowing, I love that actually. I'm going to file that away for myself. Sometimes we actually really do want to know or understand as best as we can, especially if it's not making sense to us and we don't know which direction to go in with treatment. I think just taking a pause and again, getting people from the community, again, getting people who are native and speaking that language to see if we can all brainstorm or problem solve together to understand this experience.
Great points. Lisa, I have a question from a viewer, and one of our goals for this course is to weave in as many audience questions as we can. This one's a little involved, so just bear with me as I read through it all to you,
Okay.
then you can weigh in. You and I assume the two of you said earlier that we should go at the patient's pace, which makes sense. We are being told by our organizations to ask about pronouns, though, in the first session, or insurance companies are mandating our asking about gender preference in their annual psychiatric wellness visit. Any suggestions for how to navigate these requirements? I don't want my patients to feel like I'm pressuring them for this information, but it's unfortunately necessary.
I find that usually when I ask someone what their pronouns are, they're pretty comfortable telling me. And I think if people are nervous about doing that, you can start by saying, my name is Lisa, and I prefer she, her pronouns, right? To model that we're not going to make any assumptions about what they are. And this is just a small way in which we can express our respect, right? Like, I'm curious about how do you identify? Is that important? And I think that with practice, it gets easier, right? And you might start by just saying what yours are. For example, like when we have our staff meetings, all of our team have our pronouns out because we want to make that something that's part of the common conversation that we have. So I would say, for that one, it feels like that's probably something. I don't think I've ever had anyone say, and not to say that this couldn't happen, I am offended by you asking. Um, if they are, that's a conversation in repair that you might have to have. But I think that just airing with like or starting with curiosity, I think is always a good thing.
Christine, any thoughts on that particular question in terms of outside pressures to get some of this information?
Yeah, I think I agree with the point of asking everyone, kind of sharing your own pronouns and kind of normalizing it. And when you're asking the question around how do you best identify, to feel comfortable with that, what I notice is that people kind of get tripped up because they're actually not comfortable having the whole pronoun conversation themselves. And then the
Mm.
patient can notice that. And it can feel a little uncomfortable for both sides. So I think just getting in the habit of just asking everyone to the point around people, certain patients feeling offended when you ask about pronouns. Now, I do work at a very large safety net hospital in an urban setting, and I'm just going to be real, there are some people, especially from a certain generation, cultural background, who
Mm.
will look at you differently and be like, why would you, I don't understand. Why would you ask me that question? That question doesn't make any sense, right? And it probably doesn't, given, what their experiences have been, the community that they're from, the country, all of that stuff to factor in. So if you are met with that response where you could see the eyebrows and, that kind of incredulous look,
Mm.
say to them, oh, I noticed that question seemed like it was off-putting. Can you help me understand what was behind that response? And I'll say, I don't understand what this means. Okay, well, thank you for sharing that information with me and blah, 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 So to kind of acknowledge patients' facial expressions when they're giving pushback, because sometimes clinicians will just kind of keep it moving, even though the patient is like, wait, what? But I really kind of encourage clinicians, if you notice something, say something, because then it turns into this huge pink elephant. If someone's like, wait, what? Just call it out and be curious about why they had that response.
All right, you two, I want to pause
Mhm.
for a moment and throw this out there for us. No one is perfect, and that certainly includes mental health care providers. And it is important to remember the value of giving oneself permission to grow and learn when providing care, as you two both have alluded to. I'd say it's highly unlikely that even seasoned experts are happy about every patient interaction that they have ever had. With this in mind, if you feel comfortable, I'd love to ask each of you to weigh in on a couple of different experiences. So, Lisa, can you share an example of when you caught yourself about to make a biased decision in your own work and how you address that?
Or actually having made a bias decision. Yeah, of course. And I'm thinking in particular of a young person who I saw in one gender. I'm going to try and make sure that I don't share any details. In one gender who, you know, terminated and came to see me when they were a little bit older, and then identified as another gender. And when they first came in, and this is a young person that I knew really well in this one way, when they first came in for this new session after a period of of years having seen them, I misgendered them. And I felt terrible because I saw their face fall. And the first thing I did when their parent left the room was say, I am so sorry. I missed that. And they said, it's okay. And I looked at them and I said, no, actually, it's not okay. And I will do better because I wanted to send a message that, like, it really isn't okay. And it's on me to improve and do better. And just to be very genuine and open, because we will make mistakes. We do all the time, whether we know it or we don't. This one I knew and caught. And I wanted to create a safe space for this person to come back in this new way of moving through the world and make them feel comfortable. Um, and it really helped. It was a really important conversation and it helped me orient towards those, areas of friction where I might make an error.
Christine, do you want to either weigh in on Lisa's scenario there or offer any of your own?
Yeah, I think it's important to apologize. Say if you do there is a misstep or there's an error, to apologize, to call it out, to check in on how the patient feels about the misstep or the error, and then to kind of gauge how it is that the patient is responding. I'm sometimes curious when patients say, "Oh no, it's okay, it's fine," and they want to move on. The patient wants to move on, right? Because maybe they're uncomfortable and feeling like they're going to have to make you feel, better because you feel so bad that you made a mistake. And oftentimes, people from marginalized communities feel like they got to take care of the person
That's
from the
true.
majority community when there's a misstep or an error. Oh, I'm so sorry, I didn't mean it. And then the other person's like, don't worry about it. You're okay. I know. You know what I mean? That happens all the time. So I think if a patient says, that's fine, keep it moving. That's fine. And ask them, how was that for you? Oh, I'm fine. I'm fine. And move on because you want to make sure you're not further placing the person
Right.
in an uncomfortable position to have to sit with your distress, and to make you
Very
feel
true.
better.
Mhm.
So that's what I have to say about that.
Great points all the way around. Let me turn to our bag of viewer questions again, if you will, here. Considering how strongly some folks feel about political issues, I find myself working really hard to be self aware and manage my own countertransference when working with individuals whose political views are very opposed to my own. It is almost as if their identity is completely wrapped up with their political views. As a seasoned clinician, I admit feeling exasperated in some of these clinical situations. Any tips for managing these situations?
Those are really difficult, I have to say. And I was just talking with a close colleague about this in the past couple of weeks. And she's a young clinician who was raised in an extremely conservative community that has come out of that community and is now sort of in a very different place. And she was reflecting on her own experience of that. And what she says sometimes is that when you have adherence to these, and I say this as a way not that there's a right way to do this, but this is just one of the things that when I come across people whose beliefs I find uh really in contrast and maybe even, counter to awful, I don't like them. It's difficult to have these beliefs voiced, right? I still want to make a space to for this person to have care that they might need. She talked about how sometimes when people are in particular groups, there's no, if they left that group, right? It's very difficult to find a path to belonging somewhere else. And it feels almost, and I'm sure this is not true of everyone, right? But this was just her experience, that sometimes that's a constraining factor to moving out of that group or being less extreme and things like that. But I do think it's difficult. And I will say this also, that when I feel like I cannot treat someone who has beliefs that I find that that are so counter to my values, if I feel like I cannot competently meet that person where they are, I think it's really important that we acknowledge the edges of our own experience, and I want to make sure this person has the best care. And if I feel unable to provide that, I'm going to make sure that I can find someone who can, and see if I can help with a referral. And I think that those are personal decisions. I think, you know, I try to be guided by a code of ethics and psychology. And I also try to cast a very broad net in terms of the kinds of things that I will help with and can make room for. So it's
Lisa,
tough.
thank you for that. I
Mm.
appreciate the candor. And Christine, is there anything you'd like to add to that in terms of political biases that might come into your office and how you might address them?
Yeah, I've run into this a ton over the years. And what
Mhm.
I find to be helpful for me is that I remind myself that this is about this person's experience and it's doesn't have to do with me, right? This is hard to do, to kind of separate yourself from what it is a patient is saying, especially when it comes to politics, religious beliefs, what's happening out in the world. But I remind myself, this is how this person is experiencing life in this society. This is how this patient is experiencing the world. They feel the need to hold on to these beliefs and values. And so I try to kind of separate myself from that. But then I'm also very curious, especially being a woman of color, when people have certain views and they're still seeing me, right? So that happens often too, where someone could have, certain beliefs towards people in my community or people who look like me or politics that, impact my community, but they're still coming in to see me because at the end of the day, for that patient, is about them getting good quality psychiatric care, right? And so I really like Lisa's point. Like, if things are too heavy for you, such that it's interfering with your clinical judgment, then yes, to have that humility and to be able to take a step back is really important. But I always try to remain focused on what is the mental health issue at hand? How can I be helpful? They think that I can help them. And the fact that they're having these, experiences, they hold on to these values and beliefs. There are things that we can all agree upon, like having depression doesn't feel great, right? So I try to look at what we can agree on, right? And
Mhm.
focus on that, especially given the fact that as a child psychiatrist, there's only 10,000 in the United States. So if someone's waiting long enough, for an appointment to see me, I really do have to kind of try as hard as I can to kind of check myself and, make sure that there's enough space for that patient because people are really, really struggling. And sometimes people and in certain communities, they don't really have the privilege of being able to find another provider, right? And so you could say to them, I can't treat you. And then what? Right? Where are they going to go? So I always think about that just because of the patient population that I work with. When where access is an issue, I really try to figure out how can I make it such that I'm able to continue to provide them with mental health care because that's what they want. And we can all agree that treatment could be beneficial. And I just want to help the patient get to where it is they want to go.
I have my own follow-up to this viewer question, and that would be this: in this sort of divisive environment that we find ourselves in, do you ever encounter a situation where a patient is trying to screen your own political views before seeking your care on a longer term basis? And if so, what do you do about that?
Oh,
I have
yeah.
had that. You want to go?
I like following you. It's been great.
Yeah. So yes, I have had that happen, and other clinicians in my practice have had that happen. And I think that it's important to notice that that's important to a particular client. I also know that, again, like we're going to focus on mental health here, and that may or may not be something that's going to be important in our treatment of that person. But if someone comes and is like, I'm only going to see you if you're this, that's a tough one, right? Because I'm not necessarily, it's going to be a difficult thing to navigate if really we want to be helpful around the mental health issue. So I might try to orient that person back towards um, what we can provide and what's important, and that we're going to focus on these particular aspects. But I think it's a challenge. And I also want to like dial back to just to think about the discussion previously about sort of the paucity of providers. I do think that's really true. And, I did my graduate training in a super rural, very small town where it was even more pronounced, where, I do think it's really important to make lots and lots of room to make ourselves available given the general inaccessibility of care, but especially in even, for example, rural populations.
Let me follow this up with a viewer question that came in that I think is a natural follow to this as well, because it taps into the conversation we've been having on this front. I've had more than one unfortunate situation where someone has walked into my office for an appointment, and I've watched their face change when they saw that I was not of the race or culture that they either hoped or expected me to be. In those moments, I have no idea what to do. I want to reassure them that I'm invested in their wellness and want to help, but it feels so awkward. Have you had this happen? And if so, how do you suggest reacting to these situations in a way that will be positive? Christine, can you tackle that for us?
Yes, yes. Um, so say, and I'm just thinking about all of the different first time interactions that I've had with people walking into the waiting room. Um, Luckily, fortunately now people tend to Google their provider ahead of time. And I'm happy that more and more people are doing that. They find me on Instagram first or LinkedIn. So for the most part, I'm happy that at least they've been able to do that. But there's a whole
Mhm.
group of people, given the clinical setting or a whole host of other reasons, they don't know who's going to walk into the waiting room looking for them. Now, if someone is protesting in the waiting room, that gives me a lot of information about that person because it isn't typical behavior to have a very big reaction in such a public setting when you could actually just walk with the provider, go into the office, and then share your discontent, right? And so if someone's having a big reaction, I'm actually really curious about kind of how they're doing. And so I'm actually leaning in a little bit more and
Mm.
bringing them in and just like, I see, I appreciate the fact that you were disappointed and seeing me, and thank you for coming into the room to talk to me. But I just want to better understand kind of what your concerns are about seeing someone like me. And just to have them share everything, the concerns. I do not provide reassurance, but what I say is, I just want to let you know that I'm here to take good care of you. I provide reassurance in that sort of way, like, I'm here for you. I'm here to take good care of you. But I don't go on to say, well, just because I'm Black doesn't mean that I can't take good care of you. I don't feel the need to kind of go into further explanation, which sometimes people do because of their own anxiety. Whereas, like,
Mm.
almost they have to convince themselves, like, no, 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 I can see past this, and I'm going to help you see past this, and I'm going to take good care of you. But and I'm
Mm.
actually okay if a patient doesn't want to continue to see me, that's their choice. But if they're seeing me in the emergency room, I just state the facts, right? I am the only psychiatrist here. I have to see you. You say you want to go home, but the only way you can go home is to have a conversation with me. So sometimes I just state the facts, right? You have to talk to me, but it depends on the setting. If it's outpatient, they're coming to me, then, we're kind of flexible. But if I'm seeing them on an inpatient unit and I'm the only psychiatrist, we got to make it work. And I again remind them that this is about their mental health care. And, I say to them, like, if you can't see past that, like, you're just going to continue to experience distress, ongoing distress from your symptoms for not a good reason, So I think I have a different approach just because of my own lived experience, that I'm really like accustomed to tolerating these conversations because I have them often. And maybe my kind of directness that is reflective of the fact that I've had to kind of be
Mhm.
direct. Not that I'm defensive, I'm direct, right? And I really am comfortable pushing back, but that's because I've had to do that my whole life.
Yeah.
Christine, I would like to think that in this day and age, what you've described in terms of pushback is rare. Is it accurate to say that, or is this something you're facing more commonly?
Yeah, I think racism continues to exist, and I will continue to experience racism for the next 80 years or however long that I'll live. It's just a part of society, unfortunately. And I think
Mhm.
that everybody on this call should acknowledge the fact that racism exists. It does. It does.
Mhm.
Even though you may have the experience in navigating the world and not having racist views towards other people or folks in your community, you are not racist. There's a whole other segment of the population that has a totally different experience, right? And so there are things such as microaggressions or other forms of racism, other manifestations of racism that continue to happen, right? And so maybe I don't have the experience on a regular basis of someone coming to see me being like, I don't deal with Black people. No, 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 I don't trust people like you. I don't get that. But I do get experiences like, well, I'm still waiting for the doctor to come in. And I'm like, interesting. I introduced myself as Dr. Crawford, or an experience in which I continue to remind a patient my name and they continue to call me Christine. And so these are the various ways in which I experience racism. It comes in all shapes and different flavors.
Thank you for all that candor. I appreciate that very much, Christine. It's such great context for our conversation. Lisa, do you want to add anything from your perspective in terms of some of these issues that Christine has brought up?
I was just thinking, I wanted to piggyback on the earlier discussion, and I totally agree with everything that she just said, and I think it's really, really important to acknowledge that. And I was thinking about the questions that we had, the couple from the audience, and it seems to me like there's a piece here about, when we're interacting with folks who identify differently, who appear different than us, who aren't our race or culture, religion, or whatever, you know, I think something you said earlier, Christine, is really important. Like if a client has a response, notice it, and that might bring up emotion, right? Like, oh, did I get it wrong? Is it uncomfortable? And I think we need to stay there and we need to ask those direct questions in exactly the way Dr. Crawford is describing, right? And I think I would encourage, you asked me earlier about for newer practitioners what they might do. And I think one of the things is we're going to have a lot of feelings, thoughts and feelings about a lot of things, all of us. And staying and listening and paying attention to our clients and patients, even in the presence of hard emotion, is going to be really clutch and really key to moving forward in some of these things. Um, and yes, I think I completely agree with everything that was just said.
So many questions for both of you, and they're coming in from our viewers as well. So we'll work some more of those. And let me ask you this one. How can a provider help a patient navigate internalized stigma or cultural shame without invalidating their beliefs or their experiences? Christine, thoughts?
Yes, I like this question
Mm.
very much so. Um, I think one approach is to validate the person's lived experience. So, say if they are experiencing a lot of kind of internalized stigma around having a mental health condition just based off of how they were raised and their community. And they're concerned that they're going to be viewed differently or not accepted in the community. What I do is I tend to acknowledge and affirm the person's lived experience, and I'll say things like, I hear that. I really hear that from, from your community. This is the perspective. Or I hear you when you really talk about the concern that you have about feeling accepted or feeling like you belong to your community. I hear that concern. And then I'll take it to the next step. And this is kind of tricky. But then I'll ask the patient, I wonder if there could be any consideration to be open to the idea that the alternative is true. I wonder if there could be a world in which you could still be a part of your community and believe this or receive treatment. So, again, that's the curiosity piece because for a lot of people, when they have this internal experience, it's being reinforced by their community. That's all that they know, that's all that they experience. And maybe they haven't had an opportunity to open up their mind to alternative realities or other possibilities. So over time, what I try to do is I try to push the patient a little bit each time to take a step back and think about another alternative, to think about another reality, to imagine what it would be like if things were approached differently. And I've noticed that that is really helpful for a lot of patients because it really invites this idea of being more flexible in their thinking around how it is they feel inside about their experience and invites a little bit more flexibility around how they can live life differently. And I do think that when folks experience some of this internalized racism, internalized stigma, it can feel somewhat rigid in nature. And so by asking these questions, by subtly pushing the patients, I just try to see if I can loosen things up and kind of loosen up some of these thoughts and beliefs that they're holding on to that are having a negative impact on their overall mental health.
Oh, did you want to add to that,
Well, I
Chris?
just want to say I love how you phrase that I wonder if, and I love that language about that. I think it's really lovely.
Once again, curiosity at the forefront
Mhm.
there. Yeah. Um, we sometimes hear the term minority stress. What does that get at, Lisa?
Well, it gets at that if you are part of a majority group, generally speaking, there are fewer things in the world that are dangerous that you need to be worried about. If you are a part of a minority group that is marginalized, you have less access to resources. You may be viewed in a more negative light. You certainly, and less resources across generations, right, that are systemic. For example, less access to money, less access to being able to get a mortgage, less access to obtaining education, etc. And so minority stress is something that's additive for folks who belong to minority groups that can contribute to more stress and thus greater vulnerability to things which are hard. And I think it's important to acknowledge that as we treat.
Christine, anything you'd like to add in terms of that topic? 'Cause I have some specific questions about the compounding effect that Lisa referenced there. What do you find to be that compounding effect?
I think that having ongoing experiences to reinforce the experience that, there's been ongoing discrimination, marginalization, racism, and to, navigate this world and continue to experience that can be a challenge. And what I oftentimes like to say to people is that walking around, coming from a marginalized community, is like walking around with a sticky suit, right? You have one experience that stays with you. Someone, says a microaggression that stays with you. All of these things just pile on. And what people need to understand is that minority stress doesn't just begin once you start college or you're a young adult. This happens from a very young age. This happens from the jump. When you're a baby, when you're in preschool, we're seeing this from the beginning, right? And so imagine this when we think about this is a terrible statistic that I always think about. When we think about preschool age kids, Black preschool age kids make up a small percentage of overall preschoolers. But for some reasons, they account for way over than 50% of the
Mhm.
preschoolers who get kicked out of a daycare or get kicked out of a preschool, right? For the same exact behavior that another preschooler is doing, right? And so from 3 years old, we're already saying your behavior isn't accepted here. You do not belong here. We don't like you. Get out of here, right? We can't tolerate you and your behavior, right? So that's one thing that sticks with them from, even before they're in kindergarten, right? The other thing that's important to remember is the key word stress, right? And as a physician, I'm thinking about the physiological impact
Mhm.
of this stress and its experience in the body the same way any other stressor is experienced. So I'm thinking about the impact that it has on one's cardiovascular health, thinking about their metabolic health, and then wondering why there are certain health disparities that exist that are reflective of chronic medical conditions like hypertension or diabetes or obesity, right? It's the stress of not only just being a human being, but a human being that also has been carrying this chronic burden of minority stress, right? And so we have to appreciate the fact that this is contributing to worse health outcomes. This is contributing to worse mental health outcomes because of the impact that it has on one's physical health and their mental health.
Lisa, when we're talking about building trust, and this is sort of an undercurrent to the entire conversation today, building trust with patients, talk a little bit about some of the nonverbal cues that might be relevant to the conversation here as well. We've talked about how language, explicit language, can be a factor for cultural or other identity aspects of a relationship between the patient and the provider. What about some of those nonverbal cues?
Wow, that's a really good question. And, I think that for me, what I try to do is really be present with my client. And if I'm in my head spinning, trying to figure things out, I'm not really with them. And so as I'm observing, I want to be observing what are the effects of my behavior on this person, right? Maybe I think that eye contact is a really important thing. And my client, I'm noticing, is looking away. For example, if I'm working with an individual who's autistic, guess what? That might be an incredibly painful and not important thing for them. And in fact, is incredibly off-putting and making it very difficult for them to feel like they're building a relationship with me. And so what I'm going to be doing is really paying close attention while I'm in the room for, are there things that I can do to make you more comfortable, either asking or not asking? I think something that we do as clinicians without even knowing that we're doing it is mirroring sort of our client's posture, affect, and things like that. And there's some data on that. And I think that that's important. But when we find these sort of jarring ruptures, I think it's important to slow down and kind of notice, what was I just doing? What did I do? Because there might be, you're asking about nonverbal, something about things to say, but ways of saying things might be very important. Um, posture, facial expression, all of those things. How am I dressing? Is that appropriate? Is it acceptable to my client? So thinking about all of those things and how they might impact someone. Um, yeah. And if there are particular conventions, for example, I'm thinking of, traveling with my daughter in, some Muslim communities. Like, should I be covering something up? Is there something about my appearance or my dress that's offensive? And really being mindful of that, if that's important to the person that I'm with.
Great points. Christine, anything you'd like to add to that?
Now, one thing that I do when it comes to meeting with new patients, especially if I'm able to complete a full evaluation, I'm seeing them for a follow-up. One of the first questions I oftentimes like to ask patients is, all right, well, it's so great to see you again, but I wonder, what was that experience like for you to sit with me for 60 minutes a month ago? How did you feel after that session? Did it bring up any thoughts or feelings for you afterwards? Just wanting to get a sense of
Yes.
if anything came up during and afterwards, right? And to explore that at the beginning of that follow-up session, because the fact that I'm curious about it, that I'm giving them the space to talk about it, again, allows the patient to build further trust, to feel comfortable with me, for the patient to be like, this person actually really cares. I'm not used to being asked, this question. And so that's one approach that's been really helpful for me. And I've noticed that patients really appreciate it because there's an opportunity for them to say, you know what, I actually felt really uncomfortable being in the room with just you because you're female. And I was thinking afterwards that I should have had someone else in the room. Good to know now. So then maybe we could think about what future visits would look like. Or if I see that someone is visibly uncomfortable during the session, I'll stop and I'll say, I can't help but notice X, Y, and Z. I wonder what's behind some of that. Is there anything that I can do to make this experience more tolerable? So just phrasing some questions like that. But one thing that I really do think is important to add to this conversation, especially for our new clinicians, it can almost feel like you have to come into these patient interactions or these patient encounters like just very sterile and just kind of blank, right? And sometimes people do that out of fear that they
Mhm.
might offend someone, say the wrong thing. And so you also don't want to present as not being yourself, present as
Right.
being cold, distant. So as you can see on this call, I am a lot. I have a big personality, but I'm able to, not that I tone it down, but I still show up as my true authentic self. But that looks different in a clinical space than it does for a webinar, that it does when I'm hanging out with my friends, than it does when I go to the mall. So you could still be you, but over time, hopefully you can develop your own clinical identity, your professional identity that still remains true to you, but it will still allow you to connect with your patients.
Christina, it's like you're reading my notes here because my next question to put out to both of you was this. What if I am a newer clinician, newer to the field, and I'm just genuinely nervous and anxious about addressing these topics in my clinical practice? What suggestions do you specifically have for somebody who might be in that position? And I'd like you both to say a few words about this. So, Lisa, why don't you go first?
What should you do if you're nervous? That's a great question. And I think the first thing is inside yourself, make room for being nervous. It's okay to be nervous. That's not your enemy. What it says is that you care about this person in front of you and you care about the quality of the work that you're going to do. So you've got some skin in the game here. I think that's important. The second thing I would say is stick to the guiding principles that we've been talking about, right? Have the intention of humility and curiosity and warmth. And maybe is an intention to set is to just be observant, ask good questions, listen for the answers. And again, I totally think you should be authentically you because there's nothing more off-putting than a clinician who is sort of faking it in some way, shape, or form. Like that would send me running. And I know it would send a lot of clients running. I think it's really important to meet people where they are as you are, right? With the sensitivity that you can bring to that. So make room for being nervous. I think it's important to be nervous. We are nervous about the things we care deeply about. So it's just a sign that you're invested.
Christine?
Yeah, I think it's helpful to just call it out but to do so in a way that will still make the patient comfortable to talk
Yes.
to you and to open up. So what that can look like, if you're really nervous, you could say something along the lines of, I want to be respectful, but I might not get the language right, or I might not fully understand or appreciate your perspective. And so if that's the case, feel free to interrupt me and just share a little bit more insight. So again, that, I can really just understand your perspective, because I'm doing all of this in the spirit of being able to take good care of you, right? So it's not like, I don't want to use the word permission. It's not like I'm granting the patient permission to interrupt me, but I think I'm more inviting the patient, to feel free and comfortable to correct me if I got something wrong. Like, I'd rather a patient interrupt me in the moment and say, no, 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 that's actually not right, or no, 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 you're mispronouncing this and that, um, than them walking out of my office, reflecting over that for a whole month, being like, man, she got this wrong, she didn't get that right. And then they don't show up for the next visit, right? And then
Right.
they go on to not like being on their medication, and then problems arise, right? And so I really try to create like a framework for how patients can navigate the encounter with me, and I provide them with options and with tools for how it is that they can get the most out of that clinical encounter. And so one example of doing that is to invite them to say, interrupt me if I got it wrong. It's fine. But also to not take it another step further and place this burden on the patient to like totally educate you on everything, the
Mhm.
historical context, and say something like, as much as you're comfortable sharing, do you mind just helping me better understand this perspective? And to see where that goes.
Can I add one more thing to that? I thought that was
Please do,
great.
Lisa. Yeah.
So if you guys have heard me speak before, I teach acceptance and commitment therapy, and there's this piece that's come up a few times about, like, I think a concern sometimes that we have as practitioners is that the fear that our patients will need to rescue us from our own emotions. And so when we talk about things like feeling nervous, when we talk about things like, like, oh, I got it wrong, or whatever it is, making room for those emotions models that you are perfectly capable of having those emotions and getting feedback at the same time. And if you project that genuinely and honestly, your clients hopefully will not feel at all like they need to rescue you, and will, as Christine suggested, to give you the feedback that will help you do a better job treating them. And this question comes up a lot in trainings that I do, like, is it okay to show emotions to your clients? And my answer is, it depends. Depends on how you show up with your own stuff. If you can make room, you're also providing a beautiful example of how to do that for your clients.
I
All
love
right.
that. I just want to build off of that. I'm so sorry,
Go
Jeff,
for it.
but someone
No,
who
no, please.
works with medical students.
Yeah.
These are folks who are going through it for the first time, right? And they're
Mhm.
students. Um, and this comes up time and time again. I do think that it's important for people to feel comfortable making the mistakes, and also if they are struggling to navigate or manage their own emotions when it comes to certain patient interactions, I always tell them at the beginning of our preclinical module in psychiatry, at the beginning of the clerkship, that you need to figure out what you need in
Mhm.
order to manage and navigate really big emotions that might come up during this class or during this clerkship. You need to do the work and you need to figure that out now. And I tell them, I'm like, you have all these years in med school to figure out if it's, joining a running club, if that's finding a therapist, if that's finding a prescriber. Figure all that stuff out now before you get your medical license, right? And so I think a lot of students feel like they just got to walk into some of this clinical work, but you
Mhm.
actually have to do your own
Right.
internal work. So I really strongly encourage students and trainees to be in their own therapy, to understand what it's like to be in therapy, but also to
Mhm.
have a space to process your own emotions. Because I tell students, you know, there are no trigger warnings in psychiatry. Absolutely none. I don't know what a patient's going to say to me. And so I tell them you gotta, you know, really fill up your toolbox with as many tools as possible, such that if you were to experience big emotions, at least it will be manageable.
Great points. I'm really
Yeah.
glad you put that in there. I have another question for both of you, kind of a tricky one to navigate, I imagine. Let's say hypothetically you have a colleague who is less than inclusive in matters of identity or culture, or perhaps using some problematic language. Do you address that with them? And if so, how do you go about doing that? Lisa, you want to start?
Sure. Um, number one, you do address it. I think that's really important. And I think, I mean, I'm a fan of openness and I'm a fan of being gentle and kind and also direct, and having conversations. And I might engage their curiosity about like, I noticed that you use this term. How does that land with your clients? And then you might share, well, from my experience, this is something that actually is perceived actually in a pretty negative light and can be really off-putting, for example. But I think it's important to address, and to really think about how and as somebody who trains clinicians and is always learning, and like I started with, like the longer I'm here, the less I know, to sort of really be open and aware, and curious about how those our words affect things. And I think that modeling that for peers when they are making errors, or when they might feedback might be important, I think can be a helpful thing as well, in terms of you want to make sure that you're heard when you give this feedback, and that that wall of defensiveness doesn't just pop up, right? So I think thinking carefully about what are the conditions, how can we create a context in which this person can take in how this goes. And one of the things I'll talk about is what is important to you about your work. Is it important to you to be effective? Is it important to you to really serve people well? And then to think about, well, if I were to give you some feedback about something that might get in the way of that, would that be important to you? As a way in to introduce this.
Oh,
All great points.
I
And
love that.
yeah, me too. Me too.
Um,
Can you add to that, Christine?
yes. But then I was distracted by that last bit that you had mentioned. But what I was going to say is that it can oftentimes feel hard to initiate the conversation with a colleague because you're going to have to see them for the rest of the day. You're going to have to see them next week, next day, and all that stuff. So it can feel a little awkward when you're having difficult conversations with
Mhm.
people that you work closely with. But what I always try to keep in mind is that in this setting, in this clinical setting, what is more important is for the patient to receive good quality care. What is more important in this moment, in this setting, is the experience of the patient. And so that allows me to kind of separate from like, oh man, I'm cool, cool, cool with John, and I don't want John to feel this way. But I remind myself, I'm like, John is treating a vulnerable patient population who really need his clinical expertise, right? And so I'm doing it in the spirit of allowing more patients to continue to access his clinical expertise and to not let this thing get in the way of that. And so if I'm providing feedback to John and he's giving me pushback or coming at me a certain kind of way, I'm just like, John, we're cool and everything. This has nothing to do with you as a person or your personality or our relationship. But what it does have to do with, is your desire to provide good quality care, and I'm concerned that the way in which you're approaching things or the language that you're using, it might get in the way of that. That's all that I'm saying. So both things can be true. You
Love
can go
that.
out and still get drinks with John, and you can correct him when he does something wrong that impacts patient care.
Love that. And
Nothing
I want to
against
add,
John. Nothing against
right, we
John.
love John. We love
I've
John.
done a lot of missteps on this caller. So, John.
And the thing too, I think, in what you're saying is that you're making an investment in him, right? You're giving him something that's going to make him a better clinician. And that's really important. And understanding that like whatever discomfort shows up, like, oh, I'm not gonna like it. And I'm saying this to you because I trust you can take it, and I want you to be the best that you can be, you know? And I think that that's a big piece of it, to remind ourselves too.
All such great points. And my goodness, I wish we had another 2 hours to keep going on these topics because there's so much to cover. Let me see if I can work in another audience question here. How should we be documenting topics such as culture, gender identity, sexual orientation, or another client's identity factor as a key stressor impacting symptoms in a way that best represents and protects the client? And so I'm not sure if we're getting at electronic medical records or just documentation in general, but what thoughts do either of you have on that front?
I think it's important to focus more on the relevant clinical information. Um, what sometimes we see, especially what I refer to as the one-liner, kind of the identifying statement of the patient.
Mhm.
Sometimes you'll see people use, oh, it's a 34-year-old African American who lives in this community, what have you. And then the next patient is just a 34-year-old who has bipolar disorder who presents with X, Y, and Z, right? So to not make it such that if you're not from a marginalized community, you're like the default, if you know
Mm.
what I mean, and you're
Yeah,
not just calling out people who are from
right.
marginalized communities. I think that's a very important thing. So to be consistent in your documentation and only document what you think is clinically relevant, and also to be careful of not falling into any traps having to do with stereotyping or what have you, making it such that you'll ask this person a certain set of questions because you're making certain assumptions about their lived experience and you're not asking other people the same type of questions. So I try to be consistent in my line of questioning while also allowing space for someone to share those stressors, to share their lived experience. But I try to be as consistent as possible with how it is that I'm documenting, how it is that I'm navigating the patient interview so that I can really make sure that I'm left with the information that's most clinically relevant and putting that in the chart. The one other thing that I'll say is that whatever goes in the chart stays in the chart. It lives in
Mhm.
that chart. No
Mhm.
matter who you are, what your discipline is, what your background is, once it's been said, it lives there, right?
Mhm.
And patients have access to this information.
Mhm.
And so just to be mindful of the fact that someone else is going to read it, more importantly, your patient's going to read this information. So again, you just want to stick to the clinical facts as best as you can.
I
Lisa, you
totally
want to add to
agree.
that?
I completely agree. And the only thing I would add is minimum necessary, right? Like, I think it's so important. Like, we work with lots of clients that have all sorts of different kinds of thoughts. We work with OCD, for example, and some of the types of recurrent intrusive thoughts are things that people would feel really they would not want that in writing. And it's just an example from my own experience. So we document the minimum necessary, and I would only document things that are really, really important to a client that would impact their care or that would impact how another clinician might work with them. Like, so for example, I've done some work years back, actually doing Head Start work in the Chinese American community in Boston. And we would have some generational differences in how behaviors were perceived in families, right? Where if adolescents were seeming to want to fit more and socialize with more westernized kids, their parents would perceive that as a rejection of traditional culture, right? And so the only thing I might say is that culture is an important factor in how these things are perceived. But I would really think carefully about just the minimum necessary for me to treat, and then to communicate to another provider down the road so that I can make sure that there's sensitivity where it needs to be with protecting that individual or family's confidentiality and privacy.
Christine, as we move towards wrapping up this session, unfortunately, um, I want to ask you this. We've covered so much ground and touched on so many important topics. It might even be a little overwhelming for some folks who are new to the profession. What are your key takeaways that you hope that they walk away from this webinar with?
Yes. So what I hope people walk away with is holding on to this key principle of just being curious with your patients, just to be curious about what it's like for them to navigate this world and to really convey to the patient that you are genuinely interested in hearing about their lived experience and to allow them to do so without any judgment. I also think it's important to remind yourself it's okay to not have all the answers. Kind of like what was said before, make friends with, not knowing. And to normalize this experience as clinicians, we're not going to have all of the answers, but sometimes our patients can help us. Together, we can find the answer that makes most sense for them. And then the other thing, too, is that what patients really want from you is for you to be a good clinician, right? They're not expecting you to be the world's expert on internal stigma. They're not looking to you to be an expert on, inequities in mental health. They're looking for you to be a good therapist, right? And to just show up, with that in mind. So to alleviate this pressure or this burden, to do all of the work, to read all of the books, to watch all of the YouTube videos, but really just focus on being a good clinician and showing up for your patients and being curious and providing a safe, comfortable space for them to be vulnerable with you.
Thanks, Christine. Lisa, your thoughts, key takeaways for our audience.
I love all of that. I think same thing, curiosity, humility. I think it's important to at least do a little bit of a dive into what are the biases and the assumptions that we carry around that we might not be aware of, right? Because if we're not aware of them, we might be acting in concert with them in ways that might not be so helpful, right? So we're definitely going to make mistakes. We're definitely not going to know all the answers. And, there's plenty of times I remember when I was first learning, and even now I'm going to try and hunt for how much can I know before I walk in. But again, just bringing that humility and curiosity to these types of interactions and really making room for feedback, genuine feedback, and welcoming that feedback and implementing it so that you can be a better clinician yourself with whoever that is sitting in front of you. And then I guess the final thing I'll say that we've said from the very beginning is each individual is unique and each individual is just complex, and they've got unique histories and experiences. And so really meeting the one person in front of you as they are and making them feel welcome and safe is really going to be the most important thing, I think.
Wow. Lisa and Christine, what a gift you have given us in providing so much insight into this topic. It's such an important topic. And you both have done a wonderful job of spelling out for us some of the primary considerations that we should all keep in mind. So thank you both for your time. So much appreciated.